Welcome to This Week in Neurology. This week we're covering 10 notable papers, spanning new diagnostic frameworks in multiple sclerosis and epilepsy, therapeutic frontiers in Parkinson's disease and stroke prevention, and the profound impact of social determinants on brain health. Let's dive in. We begin with a major shift in how we diagnose multiple sclerosis, highlighted in a pair of articles from the journal Neurology. The newly proposed 2024 McDonald criteria represent a move toward a more biologically grounded definition of MS, allowing for diagnosis in individuals who present with symptoms not specific for MS or who have incidental imaging findings suggestive of demyelination. A multicenter study evaluated the real-world application of these new criteria in a cohort of 420 individuals referred for possible MS. Of the 191 participants who had either non-specific symptoms or incidental findings, nearly one-fifth met the 2024 criteria for MS at their baseline evaluation. This diagnostic yield was heavily reliant on new biomarkers. Specifically, among those who met imaging criteria for dissemination in space, 43% were positive for the central vein sign and 33% had positive oligoclonal bands in their CSF. This suggests that incorporating these biomarkers, particularly the central vein sign, allows for a definitive diagnosis much earlier in a significant subset of patients who previously would have remained in diagnostic uncertainty. Staying on the theme of advanced diagnostics, a study in epilepsy introduces a novel functional MRI technique for localizing the epileptogenic zone without needing simultaneous EEG. Investigators developed a metric called the Dynamic Functional Connectivity Peak Index, or DFC peak index. The theory is that intrathecal discharges produce fMRI activation in the epileptogenic zone and deactivation in the default mode network. This new index quantifies the rate of these opposing activations. In a study of 62 patients with medication-resistant focal epilepsy, primarily temporal lobe epilepsy, the DFC peak index was significantly elevated in the epileptic medial temporal structures compared to healthy controls. Critically, for patients who went on to have surgery, resecting regions with a higher index correlated with better seizure outcomes. This was true even in patients who were MRI negative for hippocampal lesions, suggesting this technique could provide unique, non-invasive information to guide epilepsy surgery in challenging cases. Turning to therapeutic innovations, a phase 1 trial in Nature Medicine reports on a new dual-target gene therapy for Parkinson's disease. Current gene therapies often target only the AADC enzyme, meaning patients still depend on exogenous levodopa. This new approach uses a single adeno-associated virus vector to deliver genes for both rate-limiting enzymes in dopamine synthesis, tyrosine hydroxylase and AADC. The goal is to create autonomous dopamine synthesis directly in the putamen. In this open-label dose escalation trial, 10 participants with moderate to advanced Parkinson's disease received bilateral intraputaminal infusions. The primary outcome was safety and tolerability at 12 months, which the trial successfully met. There were no dose-limiting toxicities or serious adverse events related to the therapy. These promising safety data support the continued clinical development of this dual-gene approach. In the realm of stroke prevention, a phase 2 randomized trial in the journal Stroke investigated the use of prophylactic tirofiban during endovascular repair of unruptured intracranial aneurysms. Thromboembolism is a known complication of these procedures. The TIA trial randomized 192 patients to receive either standard dual antiplatelet therapy alone or dual antiplatelets plus intravenous tirofiban. The primary outcome was the volume of new ischemic lesions on diffusion-weighted imaging within 48 hours. The results were significant. Adjunctive tirofiban nearly halved the median volume of new infarcts from 88 cubic millimeters in the control group to 49 in the treatment group. Importantly, this benefit came without any significant increase in symptomatic stroke, intracranial hemorrhage, or major bleeding rates at 48 hours or 30 days. While these findings require validation in a larger multi-center trial, they suggest a promising strategy to improve the safety of neurointerventional procedures. Next, we examine the powerful influence of a person's environment on brain structure and health. A major paper in Science conducted a brain-wide association study, mapping 649 different environmental and behavioral variables to children's brains. The standout finding was that socioeconomic status, or SES, showed the strongest and most consistent brain-wide associations, stronger than any other variable, including IQ. The pattern of these associations was strongest in motor and sensory regions, not higher-order cognitive areas. In fact, the analysis suggests that the well-known link between brain structure and IQ is largely driven by SES. When adjusting for socio-economic factors, the brain IQ association was substantially weakened and did not generalize when trained on higher SES subsamples. The authors posit that factors like SES-dependent sleep deprivation and stress may be driving these profound structural brain differences. This finding provides a crucial backdrop for a study in neurology that used causal mediation analysis to investigate the mechanisms behind racial and ethnic disparities in brain aging. In a diverse cohort of over 1,300 individuals, researchers confirmed that Black and Hispanic participants had a greater volume of white matter hyperintensities, a key marker of cerebral small vessel disease, compared to non-Hispanic white participants. They then asked, to what extent does hypertension explain this difference? The analysis showed that after analytically controlling for hypertension, the inequities in white matter hyperintensity volume between Black and non-Hispanic white participants were significantly attenuated, though not eliminated. This provides strong evidence that hypertension is a major modifiable mediator of racial disparities in subclinical cerebrovascular disease, underscoring that population-level efforts to reduce hypertension are a critical path toward achieving brain health equity. These macro-level findings are complemented by work at the cellular level, such as a framework paper in Cell that discusses mapping diverse types of cellular senescence in human tissues, a key process in aging and disease that underlies many of the brain changes seen in these population studies. Finally, we look at how diseases can hijack fundamental biological networks. A study in Nature provides a new understanding of diffuse midline gliomas, or DMGs, which are devastating childhood brain tumors. Using tumor network mapping, researchers identified a conserved brain network that these gliomas integrate with, functionally connecting with healthy brain circuits to promote their own growth and invasion. The degree of a tumor's functional connectivity with this specific DMG network was an independent predictor of overall survival across multiple patient cohorts. Strikingly, in cases of thalamic DMG, incidental surgical resection of the parts of the tumor with the highest connectivity conferred a significant survival advantage. This work suggests that DMGs are not isolated masses, but are deeply integrated into brain circuitry, exploiting it for their own progression. On a more fundamental level, a paper in Cell reshapes our understanding of how cellular architecture influences gene regulation. Researchers discovered that a cytoskeletal protein, microtubule-associated protein 1b or MAP1b, is surprisingly abundant inside the nucleus of neural stem cells. They found that nuclear MAP1b interacts with chromatin remodeling complexes and promotes the stem cell state, whereas its function in the cytosol promotes neuronal differentiation. In mouse models and human brain organoids with MAP1b mutations, the protein abnormally accumulates in the nucleus, leading to neuronal positioning errors, a finding that mirrors the pathology seen in patients with these mutations. This reveals a previously unknown mechanism where a cytoskeletal protein moonlights in the nucleus to control cell fate, providing a new lens through which to understand neurodevelopmental diseases. If you only have time for one paper this week, make it the study by Marek and colleagues in Science on brain-wide associations. It's finding that a child's socioeconomic status is the single most dominant factor associated with brain structure variability is a sobering and essential piece of context for every clinician. It fundamentally reframes the drivers of brain health and challenges us to look beyond the individual to the societal factors shaping our patients' lives. Here are the key takeaways from this week in neurology. First, the 2024 McDonald criteria, by incorporating biomarkers like the central vein sign, now identify nearly 1 in 5 individuals with non-specific symptoms or incidental findings as having multiple sclerosis at their initial evaluation. Second, for patients undergoing endovascular repair of unruptured aneurysms, prophylactic intravenous tirofiban appears to significantly reduce the burden of postoperative ischemic lesions without increasing bleeding risk, pending confirmation in a larger trial. Third, socioeconomic status shows the strongest association with brain structure variability in children, a finding that appears to mediate the previously reported links between brain structure and IQ. Fourth, hypertension is a key modifiable driver of racial and ethnic inequities in cerebral small vessel disease, making its control a critical strategy for promoting brain health equity. And finally, a new fMRI analysis technique that does not require simultaneous EEG shows promise for localizing epileptic foci in patients with temporal lobe epilepsy, potentially improving surgical planning and outcomes. That's your roundup for this week in neurology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence which can make mistakes. Always review the original source materials.